All right, thanks so much, everyone, for joining today. So I'm presenting the first results from the DISCOVER INOCA Registry and the initial description of the study as well. So my disclosures are research funding and then off-label use of acetylcholine. So background information, of patients who are referred for invasive coronary angiography, 30 to 50% are found to have non-obstructive coronary arteries. We refer to these syndromes as ischemia and no obstructive coronary arteries, or angina and non-obstructive coronary arteries, or INOCA. These patients are at increased risk of major adverse cardiovascular events and cardiovascular mortality, but the long-term prognosis is not well defined. Compared to patients with obstructive CAD, these patients are more likely to suffer from anxiety, depression, and recurrent symptoms. The DISCOVER INOCA Registry is enrolling patients who are referred for invasive coronary function testing. The study objectives are, number one, to describe the prevalence of INOCA phenotypes with pre-specified diagnostic criteria. Specifically, we're looking at coronary microvascular dysfunction, vasospastic angina, mixed syndromes, myocardial bridging, and non-cardiac chest pain. Number two, we'll characterize the burden of epicardial vessel atherosclerosis and myocardial bridging, both with angiography and intravascular imaging, and we'll have core lab assessment for both. And then finally, we'll characterize the natural history and outcomes of patients with INOCA and determine variables that are associated with major adverse cardiovascular events. The study is designed, which you can see with the QR code there. The target enrollment is up to 500 patients at 10 participating sites in North America. Every patient will get a diagnostic assessment with coronary angiography, acetylcholine testing, coronary physiology with the CoroFlow system, intravascular imaging with either IVUS or OCT. We collect patient-reported outcome measures at baseline, which you see here, and then with serial assessments at 30 days, 6 months, 12 months, and then annually for 5 years. The primary endpoint of the study is major adverse cardiovascular events, defined as a composite of cardiovascular death, MI, hospitalization for cardiovascular causes, or coronary revascularization. The key inclusion criteria, so we're enrolling patients who have suspected ischemic heart disease and are enrolled for clinically indicated coronary angiography. Patients must have no obstructive coronary artery disease, both angiographically as well as physiologically. Patients are excluded if they have any MI within 90 days, and so specifically we're looking at patients with INOCA but not MINOCA. Patients with prior PCI are also excluded, and then patients with cardiomyopathies, including reduced EF or infiltrative myopathies. So today I'll just show the initial description of the first 100 patients, and we're actively enrolling as we present this. So for the first 100 patients, the average age is 57 years. 20% have a prior history of coronary artery disease. A significant portion have cardiovascular risk factors. The sex characteristics, so 79% of our cohort are female, and then you see the race breakdown here, which I think this is really representative of our patient population, but unique for studies in interventional cardiology. Baseline characteristics, so 53% of our patients that have been enrolled have had stable angina, 47% had symptoms that were classified as unstable angina. For patients with stable angina, the CCS class was predominantly class 2 or class 3 in over 75% of patients. And for patients with unstable angina, the majority were class 2. And so for class 2 by Braunwald classification, this is rest symptoms that's subacute, so it has not occurred in 48 hours. And so predominantly, this is the vasospastic angina cohort. The diagnostic yield, so for the angiographic diagnosis, 43% of the patients enrolled had normal coronary arteries, 59% had non-obstructive coronary artery disease, and then the physiologic diagnosis was microvascular dysfunction in 20% of patients, vasospastic angina in 40% of patients, a mixed syndrome of microvascular disease and vasospasm in 16%, and then other for 24%, and that includes 12% with symptomatic myocardial bridging. So with that, we changed the pre-procedure diagnosis in 91% of patients using this protocol. And then we had a change in medication based on the testing in 76% of patients. Just a brief look at procedural characteristics. 64% of these cases were done with radial access, 29% with femoral, and a small minority with radial to femoral conversion. Importantly, there were 0 periprocedural arrhythmias, 0 complications related to acetylcholine testing, and 0 wire-related safety events. There was 1 access site hematoma, and then 1 event that was coded as a stroke. And it was actually an interesting case. A patient had reversible cerebral vasoconstriction syndrome after his procedure, an NIH stroke scale of 15 that completely resolved within 2 hours. So in conclusion, DISCOVER INOCA is a prospective multi-center study of INOCA patients that integrates angiography, physiology, and intravascular imaging. We will determine the prognosis of INOCA using standardized phenotype definitions, core lab analysis, and scheduled adverse event assessment. Enrollment is ongoing, and the entire study protocol is available open access with simultaneous publication in JSCAI. So I'd like to just thank our study team, including my co-principal investigator, Dr. Alexander Lansky, the Yale Cardiovascular Research Group, who has done an incredible job conducting this study, and then our funding agency is Abbott Vascular. Our executive committee is people who have extensive experience in this area and have really made this study what it is, and then our site investigators who are continuing to enroll diligently in making this study successful. So the entire protocol is available in JSCAI today, and really it's step by step, so if anybody wants to adopt it, it's ready to go. Thank you very much.
Thanks, Samit. With the results you've got so far, how do you think they compare to current literature? Has there been anything that's surprised you? It looked like a fairly standard spread of diagnoses and patient demographics, but has there been anything interesting that's appeared so far?
Yeah, that's so we think about this both with our local cohorts, and then every investigator that's enrolling also kind of keeps a data set. And so I think the diagnostic yield, like you said, the breakdown of diagnoses is similar. The one thing is that we've had a high prevalence of vasospasm in this cohort, and I'm not sure if it's because those are the patients who are being selected to be enrolled, or if more of the microvascular dysfunction patients had prior PCI, because they would have been excluded from this. And so in this sample so far, 40% had vasospasm, and that was more than microvascular disease. So that was one surprising finding. And then the rest, I think radial access was a surprise. I think that you had mentioned that you thought femoral access was going to be more common. So we'll see as we continue to enroll how the rest of the data looks.
And you said the medical therapy has changed in quite a number of patients with their change in diagnosis. I'm interested, when you do the intracoronary imaging assessment of plaque burden, has that changed medical therapy much? More people going on statins? Or?
Yeah, so anecdotally, we do these monthly case reviews where one of the investigators presents cases, and so we've had a number of cases where IVUS or OCT will show a significant plaque burden. So these vessels that we describe as non-obstructive will have a high burden of atherosclerosis, and so I had a case where a person had a fairly benign lipid panel but had really extensive atherosclerosis, and so I think as we do more of this, and with this DISCOVER INOCA protocol, we're going to see how valuable it is in somebody with open arteries to actually image and see what their plaque characteristics are.
And they don't have any angiographic or physiological follow-up, is it? It's all symptom and event-based, isn't it? Okay. Does anyone else have any questions? Okay. Thanks very much.
Thank you very much.
We'll move on.